Wow, what a gathering. My name is Boris Lushniak. I happen to be the Dean of the School of Public Health here at the University of Maryland, College Park. And part of the team, and it really has been a team, that has put this meeting together. This is the 6th rendition of this meeting. And every year it grows. Every year it shows the incredible talents and passion and devotion to mission that we see within our student population, that we see within our connectivity between College Park and the University of Maryland, Baltimore, our connectivity with multiple partners out in the world of public health action. And most importantly, it allows us to gather once a year like this, in the midst of National Public Health Week, to acknowledge the important role that public health plays in our society. We have an incredible program here today. We'll have an incredible keynote speaker that I'll introduce at the end of this welcoming session. But in essence, to show you sort of the partnerships involved in putting this together, I'd like to introduce a series of welcoming remarks that come from all corners of our University of Maryland family. And first and foremost, on behalf of President Lowe, who couldn't be here today, but we are so lucky to have Mary Ann Rankin, the provost at the University of Maryland here in College Park, to welcome us to this meeting. Mary Ann, if you will.
Well, good morning, everyone. Good morning, everyone. I should know to wait. It's really a great privilege and a very great personal pleasure to welcome you all here today. I know it's going to be a wonderful day. President Lowe sends his best regards. Apologies for not being able to be here himself. And I have to say, I've been here for most of these, and I'm so pleased to be a part of this, the 6th of these joint events that we've put on together with our wonderful partners in Empower, University of Maryland, Baltimore. This is, in a way, a celebration and an embodiment, really, of all that is going on in Empower and with this partnership. It's just been an extraordinary series of increasingly deep partnerships, exploration of opportunities, and connections across our 2 campuses. It's really very wonderful to watch, and I know you'll see it today in the many presentations and posters and so on that you're going to hear. The continued success of this day, public health research at Maryland, it reflects really the commitment of both University of Maryland College Park and University of Maryland Baltimore in promoting public health research and well-being for the residents of this state and the region and the nation, really. It's a wonderful demonstration to ourselves and to people in this region of all that is going on here together between our 2 universities. It's wonderful also to recognize the partnership that our 2 universities have with foundations, working hand in hand, trying to make our world a better place. And I'm so happy that Dr. Richard Besser is joining us today from the Robert Wood Johnson Foundation and engaging us in reimagining health. This is a great example of working with a really extraordinary foundation. Actually we're doing a number of other things with this foundation as well. It's really super. Impressively, this year has yielded the largest number of student poster presentations that we've ever had in all our 6 years, so 120, with a large number of undergraduates participating as producers of these posters and research, of course, and as well as graduate students. This 6th year marks the largest gathering of participants overall, over 900 in total. And finally, it's important to recognize that of the 18 schools across our 2 universities, 14 of them are represented here today in posters or presentations of some sort. Panelists or moderators, whatever. So this is really a true testament to the shared commitment across our 2 universities to public health research, and public health outreach to the community. So once again, thank you all for being here. Oh, I mustn't omit saying congratulations to our School of Public Health on its 10th anniversary. We had a celebration last night of some of the champions of these 10 years. Dr. Lushniak was an amazing master of ceremonies, but anyway, I'd like to take a moment this morning to recognize this very important anniversary, a landmark in progress, and Boris is really a symbol of the progress we're going to enjoy in the future, along with our partner from UMB. So once again, thank you for inviting me to welcome you all. Thank you all for being here, and I hope you enjoy the day.
Great, thank you so much, Provost Rankin. And now, a good friend of mine, one that's become a good friend over this past year since I've become part of the TERP family. I'd like to introduce the president of the University of Maryland in Baltimore, Dr. Jay Perman. Jay.
Thank you, Boris. Thank you, Provost Rankin. I was trying to remember as I drove down how many years we've been doing this. Is it 5? 6? Wonderful. Well, they've all been good. This one's going to be the best. I, too, as Provost Rankin mentioned to you, am grateful for the support that both universities have shown this initiatives. And it's great to be with colleagues, in addition to the provost representing President Lowe, Dean Lushniak, Dean Reese, Dr. Magaziner, Rich Besser, Dr. Rich Besser. You're going to see what a star this is, what an important person in our public health sphere this is. I had the privilege once upon a time of being his teacher. I don't know whether I made any impact at all, but we had some good days back at Hopkins. It is a privilege in general to be among colleagues who prioritize the research to advance the public good. As the provost reflected, and I'm glad to recognize our provost at UMB, Bruce Gerald, as well. As Provost Rankin mentioned, our universities have quite a bit of experience with partnership. And now more than ever, it's incumbent upon us to use this power of collaboration to address the critical public health issues facing our state, our region, our nation. It's important that we conduct science that shows what works and what doesn't, in turn to create enlightened public health policy, to advocate based on those policies for those who cannot advocate for themselves. It's important that we address the social determinants of health that keep medically vulnerable populations living at the margins generation after generation. And it's incumbent upon us to share with state and national leaders why our collective work matters, why they must invest in public health research and trust the evidence which that research yields. Now, that might mean that we also rethink how we implement and validate public health programs and policies. We might have to look broadly to friends and funders and partners that we haven't tapped into before. The word reimagine is in the literature about this meeting, and I certainly think we have to reimagine how we include the public in the research we claim to conduct on their behalf. This is an incredibly exciting time for public health research, and I am grateful to everyone in this room who's working to protect and advance the health of this nation. And if I may, in turn, introduce our next speaker, a close colleague of mine, our Executive Vice President for Medical Affairs and Dean of the School of Medicine at UMB, who has had a career dedicated to advancing the health of this nation, Dean Albert Reese.
Thank you, Dr. Perman. Dean Lushniak, Provost Rankin, distinguished colleagues and guests, and of course our eminent speaker, Dr. Bezer. It's a real pleasure to be with you again for the sixth, as Dean Lushniak calls it, iteration of this enterprise. It's a wonderful time to come back and have this discourse. I too want to recognize my colleagues from the Baltimore campus. Dr. Bruce Jarrell, the Executive Vice President and Provost, and of course some of my dean colleagues. I noted that Dean Kirschling from the School of Nursing is here, and I can't see anyone else. Of course, Dr. Alan Faden, who is the Associate Dean for Trans-Campus Research Advancement, is also here with us. I certainly want to welcome all our other deans from the College Park campus for being here with us. This is a very special event, and it's so good to see the groups from both campuses. I am looking forward to the speaker's remarks. I'm particularly interested in the speaker's wisdom and how we improve the national dialogue on health and healthcare moving forward. I'm actually excited that he is in fact our keynote speaker, and for that reason will be attentively listening to his directions. So thank you for joining us. It is such a pleasure to be here once again, and your attendance and your engagement demonstrate your commitment to public health and the system-wide partnership that we enjoy. Your overall enthusiasm, I think, is a public testament to that commitment. Let me say the School of Medicine is as committed as one could be to this partnership and to the effort in advancing public health. Last year, our School of Medicine celebrated our 210th anniversary, making us the oldest public medical school in the United States, and has had a long history of collaborating with schools and colleges on both campuses in addressing a multitude of public health issues. We have used, and in fact continue to use, rigorous research, patient care practices, and education at multiple levels, and in multiple and various fora in order to advance these efforts. One of our School of Medicine's most multifaceted departments that is very much involved in this issue is the Department of Epidemiology and Public Health. This department in the School of Medicine specializes in dealing with the causes, distribution, prevention, and control of disease. This department has also been very aggressive in advancing its mission through research. We do believe that research transforms medicine. And as a result, its efforts have been recognized in its current ranking, being number 4 among all public medical schools across the country. Last year alone, the department received over $31 million in research funding from external sponsors. This robust research and grants and contracts is in part a direct result of the partnership that we enjoy with a number of entities, most importantly, the College Park campus. As these partnerships have grown, our local communities, our state, and indeed our nation have all benefited. Moving forward, it's important for us to reimagine how we can address and further strengthen our public health collaborations, the programs, and the policies. I believe that today's discourse is an important time for us to continue these crucial discussions that will greatly impact human health and well-being. That is one of our principal goals, and therefore a setting of this sort with minds of this type can only be advantageous in advancing this cause. Therefore, let me remind us today to be very intentional about our participation as we consider the significance of our work here to provide broader opportunities for public health collaboration throughout our state. At this time, I'd like to introduce the next speaker, and that's Dr. Jay Magaziner. Dr. Magaziner is the professor and chair of the Department of Epidemiology and Public Health in the UM School of Medicine. Dr. Magaziner.
Thank you, Dr. Reese, and welcome everyone. I also want to welcome everyone to this wonderful gathering of two-campus initiative to strengthen our efforts in public health. And Dr. Reese, your endorsement and support has been particularly valuable, and I appreciate that greatly, and I know we all do. Before moving to the main part of our program, I want to acknowledge a few people. First, Dr. Bruce Jarrell, who is Executive Vice President and Provost and Dean of the Graduate School at UMB, who together with Marianne Rankin, whom you've heard from, who is Provost here at College Park, have essentially led the Empower the State initiative, which has underwritten this collaboration, both here with the public health efforts, as well as many other efforts across the campuses. And I would say that many, if not all of them, have tremendous public health relevance. I'd also like to thank the associate deans who have joined us today from the various schools and campuses, and let me just mention a few. Drs. Sivan, Faden, and Rogers from the School of Medicine, our associate and assistant deans, all focused on extensive aspects of research. The focus of their efforts are research which relates to public health, spanning the bench from the molecular level all the way out to community efforts. Dr. Jenny Owens from the Graduate School is Executive Director of the GRID, or Graduate Research Innovation District, which is a new initiative, which also is another Empower initiative that is very much thought of as a way of bringing people together and imagining where we can go if we look to innovative dimensions of health and health research and practice. And Dr. Paul Sacco, who is Associate Dean for Research and a longtime friend and colleague of mine in the School of Social Work. I think your support not only demonstrates how interprofessional collaborations are working within the research community on both campuses, but it also reveals how public health is of such high relevance in so many disciplines. I also want to thank someone who, in helping me put my notes together, didn't mention herself, Diane Marie St. George, who is Vice Chair for Academic Programs in the Department of Epidemiology and Public Health and Director of the MPH program in the School of Medicine, and which embodies the entire campus at the University of Maryland, Baltimore. She has been helped tremendously by a colleague, Cara Longo, who, another one of our unsung heroes, who worked closely with Erin McClure to plan this event. And finally, I want to thank Dean Lushniak, who has been a tremendous collaborator since his arrival here, and before him, there were two other fine deans who developed collaborations with us, and I think we've really grown this enterprise. Before letting Dr. Lushniak take back the podium and say a few words and introduce our special guest, I want to mention the concept of imagination and reimagining. My thought on this is going to be very brief, but I do believe that sort of in an existential world, if we don't use our imaginations to make progress, we won't make progress. We'll maintain the status quo on and on and on. And we have to look at the status quo and look at where we are, but we have to use our imaginations, and we have to make judgments about where our imaginations can take us in a world that's ever changing. And I want to empower everyone here to use your imagination, think out of the box, and try to look at new ways of moving our world forward with regard to health care, and innovation. So Dr. Lushniak, you're on again.
Great, thank you. Great, so as we have people who have come in, please, there's seats to be had, and students and others who are in the back, come on up. Don't worry about interrupting my words here. What a great turnout today. As mentioned, you know, we've gone through 6 years of this, and every year, it keeps getting better and better. And the crowd gets bigger and bigger, and we become, as an entity here, more involved in what we're trying to achieve, in both public health education, public health research, and ultimately, the impact on our society. We've seen incredible growth, incredible diversity of thought, of sharing of information here. So, you know, we begin this as sort of talking about the University of Maryland family, and it is a family, right? The 34 miles that separate Baltimore to College Park, we can conquer those 34 miles. Yeah, sometimes it's a hassle, right, Al? You got caught in traffic, right? The parking, oh, there and here. But we have to get into our mindset that in essence, those 34 miles are but metaphor for oftentimes the challenges that exist in public health. And let's use a day like today to break through those types of barriers. All six schools at University of Maryland, Baltimore are represented here. Medical, dental, nursing, pharmacy, law, social work. And let me tell Jane that the work of the nursing school, nurses, how many nurses are out here today, right? You always come out. And this is critical for us to be able to instill this concept of partnerships. Out of College Park, 12 different entities, 8 of which are represented here. School of Public Health, BSOS, Ag, Business, iSchool, Engineering, Education, CM&S. Right, next year we shoot for 12 out of 12. But it's not just about Maryland. In addition, you'll see in the poster abstracts today, federal agencies, right, the work with NIH, FDA, the VA, state entities, domestic and international, universities and private institutions. So this has been a growth of a concept started 6 years ago. We're also very happy to have Richard Besser here. I'll be introducing him in just a second. We also have to reflect on what has gotten us here and how this idea of reimagining health plays a key role. Some of it comes with pain. Some of it comes with misfortune, with tragedy. We had a murder on this campus this past year that deeply affected us as a community to the core. We ended up doing is rallying around these tragic occurrences and try to determine what can make us better in the bigger picture, right? The interplay between the social determinants of health and hate and bias that exists out there. That's part of reimagining health. How health plays a role in our communities. How poverty, unemployment, crime, yes, gun violence, are now becoming part of our vocabulary as it interplays. That's the excitement. That in the midst of a tragic event, we come back and say, this will make us stronger as a society. We've heard many thank yous. I won't go through the thank yous again. But for the outside groups, Commissioned Officers Foundation, the Maryland Public Health Association, and many other groups that are present here today, thank you for your continuous support on this 6th anniversary of this meeting. And as you heard, what I really want you to think about is not the current state of affairs. It's a reflection on this past year, and I'm not being, as I keep informing my students and faculty and staff, partisan here. But this is the reality. The last year, we've been to more marches as a School of Public Health than ever before. In the last year, we've been vocalizing our support of science and data. It's key for us to stay active. It's key for us to be activists in public health. Again, we're not creating a partisan environment, but we have to be bold. We have to go out and speak about how we feel and the importance of science and data in public health decision making. So welcome to this incredible event. We listened to your comments from past years. Our hope is the panel discussions we've set up today are more interactive. But we first start off with wise words from a dear friend of mine. Now, Rich Besser and I met in the spring 29 years ago, Rich. Pretty much kind of like this month almost. March, April, 29 years ago. And you know, when you meet someone as distinct as Rich Besser, you know, that plays a role on the rest of your life. Rich and I met not at a conference. We didn't meet just in the street. We didn't meet at an academic institution. We met in Dhaka, Bangladesh, where I was assigned as an EIS, Epidemic Intelligence Service Officer, working on post-disaster surveillance. And he, having just completed his pediatric residency at Hopkins, before starting his chief residency at Hopkins, being a Williams College guy and educated at the University of Pennsylvania for medical school, shows up in Bangladesh to do good. Do good. And he and I hit it off. Two guys, right, playing one-on-one basketball, outdoing each other in the layups. But you know, we had an incredible group there in Bangladesh. And again, those types of experience led to us becoming friends. Years later, he became an EIS officer, an Epidemic Intelligence Service officer at the CDC. And then went out and went into academic medicine as a pediatrician in California and San Diego, and then came back to CDC yet again. And that began this whole process of working up the chain of command there, and ultimately serving as the acting director of CDC. At the time, I was the lead of the Office of Counterterrorism and Emerging Threats at the FDA, and my favorite moment with Rich dealt with us dealing with a crisis. This is 2009. He's the acting director of CDC, and we have a pandemic going on, H1N1, if you recall. And everyone's involved in this, and I'm the deputy incident commander at FDA. He's the lead at CDC. He's busy with his stuff. I'm busy with my stuff. And at one point, we interconnect. Two buddies in the midst of a crisis. And I remember that discussion, Rich. You probably don't remember because you were much too busy. But I remember it because at some point, he said the kindest thing he's ever said to me. as we were sharing the stressors of the moment, the decision-making of the moment, how we're going to deal with this potential public health evolving crisis, he said to me, Boris, I wish you were here down in Atlanta with me. What a compliment. And I'm thinking to myself, you know, I wonder why he says that. Is it the fact that I have been trained as an epidemic intelligence service officer? He needs my epidemiological skills? Is it the fact that I, as a rear admiral in the U.S. Public Health Service, you know, can function in crisis and he needs that support? So I'm going through all these delusions of grandeur of why he would say, I wish you were down here with me. And then, do you remember this, Rich? You probably don't. And then he says, because you make me laugh. Seriously. And I thought, here I am, the king at the CDC, and I'm the court jester. But that being said, an incredible career path. After CDC, what does he do, right? Does he hide from the limelight? No, he becomes the senior medical guy at ABC News, right? At the evening news. And now Richard Besser. I switched networks because of him. Because I was there with my daughter saying, look, there's Uncle Rich. He's on TV. And then his most recent transition, moving from that to what he describes as the happiest job he's ever had as president and CEO of Robert Wood Johnson Foundation. Without further ado, and without more storytelling, you came here to listen to his words. Ladies and gentlemen, give it up for Dr. Richard Besser.
Okay, thank you. Well, thanks, Boris. It's always hard to follow Boris. He has made me laugh through 29 years and a lot of crises, whether it was anthrax in Washington or just myriad crises throughout my life. But it is a real honor to be here today for your 6th Public Health Research Gathering. Last night we had a celebration. I was able to attend a celebration of the 10th anniversary of the School of Public Health, and what a wonderful feel in the room, just of accomplishment, of people coming together for shared purpose, of people trying to make the state, the community, the nation, the world healthier. It was it just touched me with that's what public health is all about. You know, when Boris reached out to me a year ago to come last year here, and it's like, Boris, you know, I don't know anything. There's absolutely no way I can come and talk about philanthropy and our work. But I gave him a rain check, which he followed up on for this year. One correction, though. So I spent 8 years at ABC News telling stories, and stories are really powerful, but they aren't always true. So when Boris said that in 1989 we were in Bangladesh together, that was true. But when he said we played one-on-one basketball together, absolutely false. Absolutely false. I have presidential proof of that. So in 2009, when I was acting director of the CDC, I had to go to the White House to brief the president and the cabinet on what we were doing around flu. And afterwards, I'm called into a meeting with the chief of staff, and I walk in and I bump into someone, and I look, and I had just checked President Obama. It was a pretty solid hit. And he looks over and he looks up and he says, you know, Rich, you're a lot taller than you look on television. And I said, yeah, I know. And he turns to Arnie Duncan and he said, hey, Arnie, you know, what about this guy for our basketball team? And I said, Mr. President, I'm sorry, I can't shoot. I can't play basketball. And he said, that's all right. You know, you're tall, you'll crowd the lanes, that'll work. So absolutely not. I remember us playing tennis in Bangladesh because that's a sport that I do play a little bit. But the story works, you know. If it weren't, you know, such a private small gathering, I wouldn't have corrected you on the story. So, But when I met Boris in Bangladesh, we were both at the start of our careers in public health. It was my first job. It was my first job out of residency. When I went to Hopkins as a resident, I went there because I knew there was a close connection with the School of Public Health, and that I really wanted to do public health. And as soon as I got there, I crossed the street and went to the School of Public Health, met a physician there who did a lot of global health work and said, I want to work for you when I'm finished. And he gave me a job, and that's how I ran into Boris. And it's those early experiences that can really shape your passion for a field and someone taking a chance on you. And my sense of the University of Maryland is that it's a place that really cares about you all as students and is willing to take a chance and give those experiences. I've been working in public health my entire career. And one of the things I love about public health is that you can do it from so many different vantage points. So, after I trained at the CDC, my first job was in academic medicine at UC San Diego. And I spent 5 years studying cross-border transmission of tuberculosis, doing public health epidemiologic research. And I loved it. It was terrific. We found new information. We found that it was the tuberculosis was primarily due to exposure to unpasteurized dairy products, to cheese. And all the prevention work was around airborne transmission. So it gave some information that they could use. After that, I went back to CDC and I spent 13 years in governmental public health. And I loved it. I mean, working for the federal government, to me, was just an honor. It was wonderful to work for our nation in an agency that was focused on improving health here and around the world. And it gave me the opportunity to engage in all kinds of different areas. I worked on respiratory diseases and antibiotic overuse and then emergency preparedness. And that led me to the position where I was the acting director of CDC. And then it led me to the strangest career that I ever could have imagined doing, and that was my time at ABC News. But the reason I went to ABC News was it struck me that I was being given a chance to practice public health in another way yet again. And that was through communication, talking directly to the public, retail public health. So giving people information to explain scary public health events, giving people information so that hopefully they could make better health decisions. And I loved it. I've loved really every career I've had. But after 7 or 8 years there, what I missed was the shared mission. The mission that I had and felt at CDC, the mission that I feel at the Robert Wood Johnson Foundation. And it's a group of people who are thinking every day about how they can help people lead healthier lives. That wasn't part of the ABC News mission. The mission was around news. When those missions intersected, when there was a health crisis, then it was terrific because they wanted me on to let people know what was going on, and it was pure public health. But most of the time, their mission wasn't anything to do with health. So now I'm at the Robert Wood Johnson Foundation. You have a conference that is all about reimagining health. And that's right in line with what we're trying to do at the foundation. And what we're trying to do is change how people in America think about health. And when I was hearing in the introductions all of the different schools that are represented here, it's right in line with what we're trying to do at the foundation. And that's to get everyone to see how all of these different factors contribute to health and health in America. So let me just show you a little data. The United States, we spend $3 trillion on healthcare. $3 trillion, which is far more than any other high-income country. And what do we get for it? This slide here looks at life expectancy. In the United States, life expectancy is 78.8 years. Compare that to Japan at 83.9 years, France at 82.4 years, and the UK at 81 years. For all of the money we're spending, we're not getting that greater return. This is looking at healthcare expenditures as a percentage of our gross domestic product. And you can see at the top there, the US at 17% of our GDP. The next highest is France at 11.6%, and then everyone else falls below that. That's an incredible amount of money to give us not a great return on investment. But I want to show you another slide because it's something that I became aware of fairly recently. If you add together the expenditure on healthcare with the expenditure on social services, the United States is right in the middle. All right? So if you look at the lower half of the bar, that's what we spend on healthcare. The top part is on social care, social services. The rest of the world has it flipped. It spends far more on social services. So in the United States, we're willing to pay for treatment. We're not willing to pay to prevent those diseases in the first place. So in the United States, heart disease, cancer, and stroke, conditions for which we know how to do a lot of prevention. We're not investing in what it takes to reduce that. Opioids, 115 Americans die every day in America from opioid overdose. And we're not looking at what are the factors that are driving that and how do we prevent that. I think it's a social justice issue. I think it's something that is not right and that we shouldn't see in this country. But you don't have to view this just from a social justice lens. Let's look at it from another lens. This is the national security lens. In America, 71% of people 17 to 24 years of age would not qualify for military service. 71%. That's because they're either obese or overweight, they haven't graduated high school, or they've had a run-in with the criminal justice system. That's an astounding figure. So whether you think it's an issue of everyone should have the right to health, or our nation is at jeopardy because of it, there are ways to get everyone to the same place on this. When you look at what the drivers are for health in this country, having access to a medical provider, a good medical provider, is part of it. But that's not the whole of it. I'm a general pediatrician, and through my entire career, I've practiced general pediatrics. In New York, I worked in a community clinic up in Harlem, and about 75% of the kids that I saw there were in foster care. And it was incredible. The foster parents that I met there, and the parents who were not foster parents, but the biologic parents, they wanted for their kids the same thing that we all want for our children. We want them to be healthy. We want them to be happy. We want them to have an opportunity to contribute to society. I remember this grandmother. We were up in Harlem, and she was out on Staten Island, but we had the contract for foster care services, so she had to travel to our clinic to have the kids be seen. And you know, I talked about the importance of eating right and exercising, getting a good night's sleep, you know, all of the things that we know contribute to health. And she said, you know, I can't afford the after-school program for my grandchildren to get physical activity, and it's not safe in our neighborhood for them to go out. We were based at a center in Harlem that had an after-school program, and we connected so that she could bring her kids there for free. And so she was willing to get on subways and travel about an hour every day so her kids could get physical activity there. So the idea that you know, it's all about making healthy choices. Choices is part of it. But the choices you make depend on the choices that you have. And for far too many people in this country, they don't have those choices that allow them to lead a healthy life. So 4 years ago at the foundation, we made a strategic decision that we were going to focus on what we call a culture of health and building a culture of health in America. And you know, to put it in simple terms, a culture of health means that as a society we're structured so that health is the easy option. It's not something you have to think about and work about, but we have communities that are built around health, walkable communities, communities in which it's easy to buy healthy food, communities in which it's safe to go outside, in which schools are supporting every child to meet their needs. schools in which parents are paid a living wage, so they're not working 4 or 5 jobs just to make ends meet. These are all part of health. And as we think about a culture of health, to us it's all built on a framework of health equity. Health equity, that's at the center, and it goes around everything that we do. So I want to spend a little bit of time talking about what I mean by health equity, because you'll hear the term used a lot, and it's used differently by different groups. At ABC News, we spend a lot of time focused on words and how words resonate. And it's clear that words can build bridges and words can divide. There are certain words that you use that have team identity. So as soon as you say that word, people say, oh, you're blue. Or you say that word, oh, you're red. And equity is one of those terms. And so we're trying to figure out how do we talk about health equity in a way that brings people together and starts a conversation and doesn't end a conversation. So when we think about health equity, we think about equity, we frame it as a fundamentally American value. It's all about opportunity. And it's about everyone in America having a fair and just opportunity to lead their healthiest life. It's about removing barriers that are there based on discrimination, based on racism and sexism, barriers that are there because of someone's physical abilities or entrenched poverty. That's all part of equity. And when you think about it as an American value, when you think about what our country was founded on, the concept of all men created equal, the concept in the Pledge of Allegiance that our kids do in school every day that says, with liberty and justice for all. The principle that everyone should be able to pursue happiness. We know that as a nation we haven't lived up to these values, but they are what our nation is founded on. And equity plays right into that fundamental value. As we've looked at how you talk about equity, we've turned back to that core of public health, and that's research. And we support a lot of work looking at how different words resonate and how different concepts resonate. So I want to show you a graphic that we played with. Initially, when we had a graphic for health equity, we showed kids looking over a fence at a baseball game. And there was one kid, like me, who was tall, and he didn't need to stand on, all 3 kids were standing on one box. And there was a tall guy like me standing on a box, and the fence came up to here. Then there was the next person over who was standing on a box, who was here, who could see over the fence. Then there was this little kid here who was standing on a box, but he still couldn't see over the top of the fence. And equity, we said, well, the tall guy gives his box to the kid who's short, and then everyone can see over the fence. And that didn't resonate so well. It's like, so you're taking my box away, right? It's like, yeah, but everyone gets to see over the fence. It's like, yeah, but you're taking my box away. So this is another way of talking about equity that seems to resonate a little bit better. So the difference between equality and equity. The goal here is that everyone can ride a bike. Riding a bike is good for you, it's good for your health. So in the top one, everyone gets the same bike. And you see the first person here has physical limitations. She's not able to ride that bike. The big guy is on the bike, but it's not a very good fit for him. He's going to end up with a bad back. The bike works pretty well for him, for her, and this kid here is not going to go very far. So with equity, everyone gets the bike that they need. And everyone's needs when it comes to that bike are different. So she has a bike that allows her to ride on the left. He's on a taller bike, which is good for him. She's still on a standard bike, and he's got a little bike that works for them. So the idea of equity is everyone having a fair opportunity for health. And this is seemed to be resonating a little bit better. So a little bit about who we are at the foundation and what we do. We're the nation's largest philanthropy focused exclusively on health. We have an endowment of about $11 billion, and each year we spend about $500 million on grants. And our grants are all focused around this idea of building a culture of health. And within that, we work to try and shift mindsets so that people can think about health in different ways. We work to create conditions that allow people to lead healthier lives. We use data and evidence to track and measure change. And then we work to activate leaders to get this job done. And I'll spend a little bit more time on all of that. But research is a fundamental part of what we support. So I'm looking forward to meeting some of you who are doing research and seeing some of your posters, because evidence is critically important. But I urge you not to stop at the creation of that evidence, not to stop at doing those studies. Because if you don't take those findings and learn how to talk about them in plain spoken language, you're not going to affect change. You're going to get a paper out there, which is great. But one of the things that I think the medical and public health community needs to do a much better job at is talking about our work in language that people understand, plain spoken language. And so I try and cut out as much jargon as I can. I think about, well, how would I say that on ABC News? I don't go quite that far, because on ABC News, I couldn't say the word diarrhea. I know it's a morning, but I started my career thinking I would spend my entire career working on diarrhea. That was my initial research. But on ABC News, I would be talking about a rotavirus outbreak or a norovirus outbreak. And they said, well, we want you on Good Morning America tomorrow to talk about the norovirus outbreak and what people can do to protect their health. But you can't say diarrhea. All right. So thus was born typical stomach flu symptoms. So there are ways to get there. So I want to talk a little bit about our main areas of work. We have 3 areas: creating healthy communities. This focuses on creating the circumstances in communities that allow people to lead healthy lives. And it's getting us into areas way beyond what you typically think of about health. Housing is critically important. Transportation, parks, safe streets, all of that is a part of what you need to think about when you're thinking about how do you build a community that promotes health. Healthy children and families. This is focusing on helping all children achieve optimal physical, social, and mental and emotional health, and making sure that families have what they need to provide that for their children. And then coordinating health and healthcare systems. This is making sure that a healthcare system isn't just about treating illness. It's about understanding what led to this person being there in the first place. What are their general needs? Why are they missing their follow-up appointment? Is it because the bus line doesn't run to their part of the city? And making that part of the problem for the health system to solve. So I want to touch on 3 examples of the kind of work that we support. As an epidemiologist, I'm a big believer in data, a believer that data can shine a light in areas that people were unaware of and allow them to make change. So in 2010, the foundation launched what are called the County Health Rankings and Roadmaps. And this report comes out every year. It came out a few weeks ago. And it breaks down the health status of every county in America, and it ranks them. So you can see how your county is doing compared to other counties in your states along a wide range of metrics: mortality, diabetes rates, obesity rates. And then it looks at some of the factors that go behind those health metrics, things like high school graduation rate, teenage pregnancy rate, opioid overuse rate, poverty levels, employment levels. And what it does is it lets a community take charge and say, okay, we've got these problems going on in our community. And then it links them to roadmaps, some things that other communities have tried to be successful. We found it to be very, very empowering when communities are able to compare their metrics with those of others in their state. This year, our rankings didn't just look at place, it also broke things down by race. And we've spent a lot of time this year trying to stimulate a conversation in America around race and around discrimination. We supported work by NPR and Harvard School of Public Health polling on discrimination in America that's led to a lot of conversation around race. When you look at health by county and then break it down by race, you see that after a decade of improvement, the percentage of babies born at low birth weight is on the rise. Black babies twice as likely as white babies to have a low birth weight, and also about twice as likely to die before their first birthday. Additional research showing that segregation is a fundamental cause of health disparities. Those blacks who live in segregated communities fare far worse than those who live in more integrated communities. Last year, I'm just today is the last day of my first year at the foundation, and in the fall, I was able to head out to Allen County, Kansas. One of the things that we do coming out of the county health rankings is we look for communities around the country that have taken their data and decided to do something about it. They've seen that there are problems, but they've also seen opportunities to make change. And so I went out to this rural community. Allen County has a population of about 12,000 people. It is 505 square miles. It's absolutely beautiful. You drive through there and lots of fields of crops. It's also extremely poor, entrenched poverty. It ranked 94th of 105 counties in Kansas. And they looked at this and they said, we want to make a difference. We want to change things here. And I want to just show you a short video of what they did in Allen County.
Allen County is a rural community in southeastern Kansas. For decades, it has been slowly losing population, a trend that taxed the physical and economic health of the community. But Allen County is breaking the cycle with a combination of pride, planning, and partnerships.
We aren't rich. We're scrappy. Our best asset is our people.
People judge you by your character rather than what you have or what you don't have.
I am always looking for ways to get things done around here. Some way might not work, we try a different way.
Allen County has 13,000 people spread across 505 square miles. We've had to be intentional about creating opportunities for community conversations.
Get people together and get them expressing what we need, what we want, how we could be serving each other better.
You have to communicate. You have to make people believe in themselves.
Thrive is a convener. It's an organization that can take ideas and make them real. We don't do the work, the people do the work. We look at data, we test, we learn. We've made it over a huge hurdle as a community, from the whether to the how.
MARV stands for Mills and Reading Vehicle. The kids know we're coming, and yes, we honk as we're driving up so they know that we're here. Part of getting healthy adults is you to get healthy children. I truly am a believer that we are going to cut down on obesity, diabetes, heart disease, but it has to start with feeding kids healthy meals, because that's where health starts.
We do everything from aluminum cans to combines. If it's metal, we'll buy it. I looked around the area and decided that we needed some workers around here. You know, people that knew how to do things with their hands.
So he put his money where his mouth is by buying a former lumberyard complex and donating buildings on that complex so that it could become the Regional Rural Technology Center.
Keep the jobs here, keep them here. That's what we're hoping to do. Train kids and try to keep them home.
10 years ago, we started by saying, let's build trails and let's work on sidewalks and connectivity. We were overrun with people using them. There's been a concerted effort over the last several years to bring a retail bike shop to Allen County. It's been a huge success.
So this has to move in order to keep the chain tight, otherwise the chain will fall off.
So we're talking about health, we're talking about physical activity, we're talking about economic development, and we're talking about new opportunities to socialize. You weave these elements together, and then you've got a culture of health.
You know, when I went out there, it was pretty incredible. We went to the town square, and the whole town had gathered, and there was a 5th grade drum band there, and they didn't know why they were there. They were just told to assemble in the town square, and everybody came. Like, that would never happen in New Jersey. We're a little more skeptical. But the banner was unfurled that they won the Culture of Health Prize, and the place went wild. And they gave me a big tour. This county had voted to implement a sales tax. You know, this poor county. They implemented a sales tax so that they would have money to build a hospital. Their hospital had closed. And they went out and recruited a supermarket to come to town because they said, how could we be a real town without a supermarket? And their efforts were not built around health. Their efforts were focused on economic development and how do we make Allen County a place that could draw workers. And you know, they didn't think about it as a health intervention until it was way up and running, but they wanted it to be a place where people would want to come. And if you're coming there and you've got a family, you want a place where there are things to do. So those trails were on an old cement factory, you know, that they took over and reclaimed. And the supermarket was being built, and I was talking to the vice president of the supermarket company. I said, why are you building your supermarket in this town? He said, because they called us and they really, really, really wanted it. And it was just amazing to see the power of that kind of energy. And that's the kind of thing that we're trying to support. We didn't fund this. We didn't fund their work. We gave them a prize of $50,000 at the end, and we made a nice video of their work. And they've been able to get more grant funding off of that. But what we provided, it was through the University of Wisconsin Population Institute, which does the county health rankings, we provided the data so that they could see what the problem was and they could see a roadmap to some solutions. Another area that we're focused on, as I said earlier, is healthy children and families. And this is a really interesting project that we're doing with Sesame Street. There's more and more data that shows that the traumatic experiences children experience very early in their life can have a profound impact over the entire course of their life, their health, their future, whether they're going to graduate school, how they're going to do. These things are called adverse childhood experiences, or ACEs. They are things like witnessing violent acts, experiencing a natural disaster, physical abuse, neglect. These things are profound. And there's data that shows that in America, 1 out of every 5 kids has experienced at least 2 of these events. And having 2 or more of these events is what's been linked to poor health outcomes. So we started a project with Sesame Street. It's called Sesame Street in Communities. And they've developed a whole wide range of resources that are available online to help kids deal with trauma. This is just a screenshot from a video that helps children talk about having a parent who is in jail. And this little Muppet, Alex, his father's in jail, and they talk it through, and they talk about what that means. We're now funding research that's looking at the implementation of Sesame Street in communities around the country and how effective it can be at helping children deal with these crises. For me, it was a lot of fun because I got to shoot a video with the Muppets, which was more fun than anyone should be allowed to have. And then this project here, the Camden Coalition, is a good example of the kind of thing we support in the transforming health and healthcare systems. You know, as I talked about, it's so often that the factors that lead a patient to come in and see you are not the typical ones that we're used to dealing with in healthcare. And the Camden Coalition is a very renowned project started by Dr. Jeffrey Brenner. And what they looked at were super users, those people who were the most frequent visitors to the emergency rooms, to the healthcare system. They accounted for the highest proportion of healthcare expenditure. And they wanted to see if you focus intensive services on that group of people, could you bring down costs and improve health? And so their questions when they saw people went beyond treatment. They wanted to see, could patients afford meds? Did they have transportation to get to the doctor? Did they know how to select healthy food? Did they have access to healthy food? Were they in safe housing? Were there changes needed there? And what they found was that by providing intensive services, they were improving the lives of their patients, and they were bringing down costs. The last area of our work I wanted to just mention, because it's I think when you look at the long history of the Robert Wood Johnson Foundation, the work that we've done in training leaders has probably had a greater payoff than anything else that we've done. These are, I want to talk about 4 of our leadership programs, but over the course of our history, the work we've done in the Robert Wood Johnson Clinical Scholar Program, training health services researchers, the work that we've done training nurses, postgraduate nursing, these programs have had a profound effect. But as we looked at what we're looking to do in building a culture of health, we recognize that we need to build leaders who are connected to communities in a different way. And so we have 4 new change leadership programs. The Culture of Health Leaders Program, this takes leaders from fields that you don't traditionally see in the health arena. So economics, transportation, religion, law enforcement, city planning, architecture. It brings them in and provides them with training so that they can understand how their disciplines connect to health. And they can learn how to work across with people in the health field to change their communities. They're working on areas such as safe streets and participatory city budgeting. The Clinical Scholars Program. This is different from our old Clinical Scholars Program. Here you have teams of people from the clinical world who come together to address a problem that they see in their world that focuses on health equity. The interdisciplinary research leaders, this connects people in the community who are doing work to improve their community with researchers in an academic setting. So it teaches them how to do on-the-ground participatory community research. And it's absolutely wonderful. So you have people who are the real activist leaders in their community who don't have that research background, and they're pairing them with those who do, so that they can get information that's generalizable, that can extend beyond their community and can be used in their community to help drive policy change. And then the last one is the Health Policy Research Scholars. And this is a program for people, it can be in any discipline, who are in a doctoral program. It's for people who come from underrepresented backgrounds that are not typically represented or well represented in the policy field. And it helps them learn how to take their training and be able to participate in changing things at the policy level. These programs, the application period has just closed. So for those of you who might be interested, think about next year. And I know that there are students from the University of Maryland in a number of these programs, and I look forward to seeing more in others. But one of the things I've learned in my first year in philanthropy is that we're not the doers. We look for those who are doing, who have good ideas, who are trying to change health in this country, and we're able to support those activities. And so we're really looking for all of you. We don't change policy. We don't administer health care. We're not doing the research. Those of you who are here at this school are the ones who are going to make that change. You're the ones who, through your ideas, through your bold thinking, through your challenging, through your activism, are going to make a big difference. You're the ones who are going to shape the conversation on health in America and change how we fundamentally think about that. When Boris said that almost all of the schools are represented here, I think that next year having all the schools here would be a terrific thing. I love that the School of Agriculture is here. We've just started a big partnership with 4-H. It's like, well, why are we working with 4-H? Because they're big in rural America. And rural America is often neglected in the conversation. And reaching young people in rural America to us is really, really important. All of the schools here have a role to play in health. So I wish you well on your 6th Public Health Research Day. The information on those posters may one day change the lives of people in an important way. Boris, I want to thank you again for the invitation to come here, and I look forward to your questions. Thank you.
Thank you. It's very informative. I think we have about 10 or 15 minutes for questions, and I think you can handle them yourself.
Very
you
good.
Don't need me standing.
All right. Yeah, if you could just say who you are and what school or what role you're in.
University, Maryland School of Nursing. I'm in the community public health, environmental health world. And so with the community health rankings, do any of them include environmental health factors like air? Thanks. Air, water, or pesticide and chemicals in the consideration of exposures?
Yeah, I don't think there are any in there right now, and it's not from a lack of interest. You know, as new data becomes available and at a county level nationally, we'll look to expand. We definitely want to get some environmental markers in there. It's really, really important. I'm really interested in seeing, can we get some valid markers around water quality and air quality. As we look at climate change, one of the things that we worry about is air quality, and being able to measure that and look at that is really important. When we've done a lot of work around childhood obesity, one of the things we talk about there is sugar-sweetened beverages. I worry, though, that our message of don't drink sodas needs to be followed with drink water. And if you're in a community where that's not such a good idea in terms of turning on your tap, we need to know that and come up with appropriate messaging. So work on those metrics so that we can get them in there. It's really very important. Down in the front here. A microphone is coming. I'm open to questions on anything. I love tough questions.
Sir, good morning. John McElligott. I'm with the Public Health Service Commission Officers Foundation. Question for you about the connection between economics and health. I know the U.S. Surgeon General now is going to be working on a report or a call to action tying the economic sense and investment for healthy populations. I'm wondering, when you speak with communities, what are the talking points or the data that will make the connection with large businesses or the elected officials to make that case? And are there simply communities where it doesn't make sense to argue for it?
Yeah, the Surgeon General came and spent a day with us at the foundation, and I was really heartened to hear him speak about the connection between economics and health, because it's real. You know, if people aren't being paid a living wage, it's pretty hard to lead a healthy life. One of the things that we're looking to do and have a fair amount of funding in is making the connection for business as to why investing in their community makes sense. From a business case, there's this concept of anchor institutions and the role that a large business or a large university plays in their community. The Kaiser Health System is a really good example of one where they're investing a lot in development of people in their community who can be employed by their system. They're looking at supply chain to see how much of what they need in their system can be bought locally. We were founded by one of the founders of Johnson & Johnson, and as a company, they took that approach in New Brunswick and had the approach that their first responsibility was to their employees and to the community in which they lived, and that people should be able to live in the community near where they work, work a 40-hour week, be paid a decent wage, be able to enjoy some of the nicer things in life, and provide for their family in that way. That's not the case in a lot of America. But as businesses look just at a bottom line, wanting to recruit the best workforce, people want to come to areas where it's a nice place to live. And so whether it's recruiting and retaining a good workforce, whether that's the driver, a lot of millennial workers want to work for businesses that have some form of a social vision and mission and conscience, so that they're not just looking at the bottom line, but they're looking at how they function in society. Those are ways to tie to economy. But I think it's more than saying a robust economy is going to raise all boats, because the data doesn't show that. You need to be intentional and look to see how is it affecting those most in need in your community, and what can you do to support an economy that provides for all. But that connection between economic, the Allen County example, that was an economic development program that led to health. East Lake development in Atlanta is a great example of an economic development. They took a neighborhood that had the worst public housing in the city, tore it down, started from scratch, had a whole new vision for what public housing should look like. It's now mixed income housing with half public and half market rate. They now have a high school with 100% graduation rate. It used to be 13% graduation rate. They have a YMCA on site that is the best Y in Atlanta. Everyone comes to try and go to that Y. This was all done as a way to transform this community. Nothing about health. In fact, in talking to the director for a decade, she fought any connection with health. This isn't about health. This is about people's lives. And it wasn't until like 10 years later, when she was seeing the health metrics, that she said, oh, I guess you're right. This is a health intervention. So, but I don't care. Go at it after economics. We need to be willing to meet people where they are. And whether you're talking about doing it because it's your economic development, as long as you're including the community, you're not doing economic development in a way that pushes the community out. A lot of our healthy community work is, how do you do that? How do you use land trusts and others to make sure that the residents in that community aren't just displaced as you look for your economic development? There's a lot of equity issues around that can be dealt with, but you have to think about them intentionally going in. Yes?
We're coming to you with a microphone. I just want to also say, I know we have a lot of students in the audience, and I know Dr. Besser welcomes questions from students, so I encourage you to think about that as well.
Yeah.
Thank you. I want to go back to probably the first slide, or one of the first slides you presented today, which showed the life expectancy rates in the various countries. Having been to the UK, France, and Japan, it seems to me that they smoke more than we do. So I'm just wondering, what is the reason why they have better life expectancy than we do?
Yeah, I mean, smoking is one factor. I gave a talk in Baltimore last week, and I showed a slide of Baltimore and the neighborhoods around Hopkins and neighborhoods 14-minute drive away, and there was a 10-year difference in life expectancy. So you really need to look at all of those factors that contribute to that. Poverty, unemployment, educational opportunity, and things like racism and discrimination, and systems that are structured in a way that prevent upward mobility. So it is pretty striking that in spite of having higher smoking rates, you still live longer in those countries. The back. A microphone is coming. We'll take the one in the far back first, and then.
Yeah, we'll have two more questions. First in the back, and then.
My name's Amber. I'm in the BSN program at University of Maryland. So my question, you talked a little bit about the Camden Coalition, and I'm specifically wondering if this is just based in one community, or if it can be implemented elsewhere as well.
Yeah, so my understanding is that model has been replicated in a number of places, some successfully and some not successfully. So I think there's a lot of work that still needs to be done to look at that approach of targeting the highest users of healthcare. I think that we really need to look at community level change. Yes, it's important to do the target looking at individuals, but some of the things that we talk about really involve fundamental changes in communities and how we want society to look and how we want to create a society in which health is an easy option. You know, it's one thing to give a high user a health aide who visits every day to make sure they're taking their medication and stay out of the hospital. It's another thing to make sure that the streets are safe and walkable, and there are parks, and there's access to healthy food, and there are jobs that pay people. And one last question that was here on the aisle. Yeah.
Buenos días.
Buenos días.
My name is Gloria Aparicio Blackwell. I'm here at the University of Maryland Office of Community Engagement. You're saying about asking tough questions. I'm going to ask you about the Census 2020. How much support are you giving to finding a way how we counted the undercounted? That's one of the striking factors that many communities, if they are not counted, of course the resources are not going to be there. Therefore, healthy communities could be dwindling down. So I'm wondering, what is your thought and how much collaboration are you doing with the U.S. Census Bureau to encourage that numbers to be higher than the ones that are already counted at this moment? And particularly the questions that are being asked, citizenship.
Yeah.
So I think that is one of the areas that we really need to work together to get the message out and to get people to get their voice. So I'm just wondering, what is your role and what is this organization trying to assess that?
Yeah.
Thank you.
I mean, that is a tough question. It's clear that the census is critically important to funding of many federal programs. It's critically important to representation. Adding questions about citizenship I think are likely to reduce participation by many communities. And so that really worries me. One of the things that we think about as a foundation is, okay, what issues do we speak out on? What issues do we not? And typically we'll speak out on issues where it's been core to our mission and we've done research to be able to refer to that research. And that's not an area where it fits that. But when I speak publicly, I speak out. I think that adding those questions is a bad idea. I see that there are lawsuits that are challenging those questions, and hopefully they won't be included. You know, the changes to the census in terms of online versus in person, you know, whether that will change things. The climate in the country, in which there's fear of government officials of all kinds, could have a chilling effect on the census, and that's a great concern because that will affect people's health. So thank you for asking that. I look forward to speaking with many of you over the course of the day. Thank you very much.